Usually when we talk about receiving medical care, there's this underlying expectation from all of us of total, absolute precision.
Oh, absolutely.
It's
Yeah.
almost like we view medicine as structural engineering or something. Like if you break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, "There it is. Let's fix it."
Right. Yeah. From the patient's perspective, it feels very binary. It feels incredibly clean. It's either broken or not broken.
Exactly. You receive a medication and it works or it doesn't. And as patients sitting there in that paper gown, that illusion is just incredibly comforting.
Oh, for sure. We desperately want the medical professionals taking care of us to be operating from a place of absolute categorized certainty.
Right. But the reality of how those professionals actually achieve that level of certainty, how they train for those high stakes life or death moments long before they ever touch a real breathing patient, is an entirely different story.
It's messy.
Yeah, it's messy, it's complex, and for a really long time it was surprisingly unstandardized, which is wild to think about.
It is, yeah.
And that hidden architecture of medical training is exactly what we are focusing on for today's deep dive. We're looking at a stack of historical archives, research papers, and institutional timelines.
It's a lot of material.
It is, yeah.
Mhm.
But it's all centered around one incredibly dense but profoundly impactful concept, which is the history of the INACSL healthcare simulation standards of best practice.
A long title, but so important.
Right. Now, if you are listening to this right now, I want to establish our mission up front. I want you to know exactly why you should care about a set of, institutional documents.
Because it directly impacts you. I mean, literally you.
Exactly. If you or anyone you love ever interacts with a nurse, a surgeon, a pharmacist, or any medical professional, the quality and safety of the care you receive is directly influenced by the rigorous simulation training standards we're going to explore today.
They're the foundation.
Yeah. These aren't just dusty rulebooks sitting on a shelf. They are living documents that dictate how healthcare simulation activities are designed, conducted, and evaluated across the entire globe.
Right.
Okay, let's unpack this because when a lot of people hear the word simulation, they picture like a video game or maybe a flight simulator.
Yeah, people think of virtual reality or joysticks.
Right. But in this context, it is so much more visceral than that.
It really is. When we talk about healthcare simulation, we're talking about creating a highly realistic physical and psychological environment. It's a space where medical professionals and students can practice high-stakes medical scenarios safely.
Like an actual physical room.
Exactly. Think about a sudden cardiac arrest in an emergency room or a highly complicated labor and delivery. You simply cannot practice those for the first time on a real human being. The stakes are way too high.
So what do they do?
So you use high-fidelity mannequins that literally blink, bleed, and breathe. You use actors. You use intensely controlled environments.
But here is the massive challenge that kicks off our entire journey today. What happens if every single hospital, every nursing school, and every clinic designs their own simulations completely differently?
You get chaos, just absolute chaos.
Right.
If a nursing school in New York trains for cardiac arrest using a completely different simulation framework than, say, a hospital in Texas or a clinic in London, there's absolutely no baseline for competency.
None at all.
Right. So standardizing this practice globally, ensuring that a simulation carries the exact same educational weight and rigor no matter where you are in the world, is a monumental task.
And before there could be any kind of global standard, there had to be an acknowledgement of that chaos, right?
Oh, absolutely.
There had to be a moment where the leaders in the field looked around and just said, we have a problem. Which takes us back to the genesis of our timeline, which is the year 2009.
Yes, 2009 is really the spark for everything we see today. The need for best practice standards began as a relatively simple roundtable discussion by the board of directors for INATSL.
And just to clarify for you listening, INTSL stands for the International Nursing Association for Clinical Simulation and Learning. So picture this. You have this board of directors sitting around a table in 2009. And they are realizing that simulation is rapidly becoming a massive part of medical education, but it's effectively the Wild West out there.
Oh, completely. Everyone is just making up their own rules.
Right. They identified this glaring problem without standards. They couldn't guarantee the quality of the nurses entering the workforce. But what I find fascinating is that they didn't just, panic and start writing arbitrary rules to fill the void.
No, they didn't. They took a remarkably measured scientific approach. They relied on their own collective clinical knowledge, sure, But they also conducted massive, sweeping literature reviews.
Which takes time.
A lot of time.
Yep.
And they sought direct input from their members just to figure out where the baseline should even be. They essentially took a step back to assess the entire landscape of medical education before ever putting pen to paper.
And that leads to a detail from 2010 that I absolutely love. Before they even wrote the first standard, they realized they had to develop a template, a standardized format for how the standards themselves would be written during their development. To me, that is like, it's like building the recipe box before you even attempt to write down your grandmother's recipes.
That's a great way to put it.
It just shows the deeply foundational, ground-up work that was required here. They couldn't start defining best practices until they agreed on what a best practice should actually look like on paper.
What's fascinating here is how that rigorous foundational work ties directly into their concept of these being living documents.
Right, that phrase comes up a lot.
It does. Because once they had that template, and once they drafted the first 7 standards, they debuted them at the 9th annual INCSL conference in Las Vegas in 2010.
Vegas, nice.
Right.
Yeah.
But they didn't just stand on a stage, hand them down like absolute law, and tell everyone to obey.
Right, they did the exact opposite, actually.
They presented them, and then immediately surveyed the members in the audience for feedback. Launching a version 1.0 to a live crowd of experts in Las Vegas, and instantly asking, "Please tell us what is wrong with this," reflects a deeply iterative mindset.
They wanted it to be torn apart.
Exactly. They treated the standards themselves like a simulation. They built a model, they tested it in the real world, they observed where it broke down, and they adjusted.
That transition from a private board idea to an industry-wide consensus is where the story really accelerates. Because if these standards were going to protect patients, they couldn't just live in a silo.
No, they had to be tested.
Right. So we moved from that initial spark into what I would call the crucible of collaboration.
A very apt description, yeah. They took all that feedback from Vegas, and by the time the 2011 conference rolled around, they already had a second draft ready to present.
That is fast.
Very fast. And again, they asked for more feedback. This momentum led to the creation of a dedicated task force.
Right, I saw that in the archives.
Yeah, a specific group of experts tasked with taking this mountain of peer feedback and synthesizing it into final documents for actual publication.
And they pulled it off. In 2011, the standards were officially published in the Clinical Simulation in Nursing Journal.
A huge milestone.
It's a massive leap from a roundtable discussion just 2 years prior. Now, they have a published baseline, but they didn't stop. They kept revising based on new clinical data, publishing a second edition in 2013.
Right.
But here is where we hit a critical juncture. Once they had this robust internal standard, they hit a strategic wall. If only INACSL members are validating the INACSL standards, it runs the risk of just becoming an echo chamber, right?
Exactly. And breaking out of that echo chamber is what defines the next major era of these documents.
And this is the part of the history that I really want to dig into with you because it honestly kind of baffled me when I first read it.
Oh, yeah.
Yeah. By 2014, the organization made a massive decision. They invited 20 outside healthcare organizations to review and provide feedback on their standards. Ultimately, 16 of those external organizations completed the review and sent back their critiques. Now, let me push back on this for a second, just representing anyone who has ever managed a big project.
Go for it.
Why on earth would you invite outside organizations to tear apart your hard work? I mean, you have a published second edition. Your members are using it successfully. Isn't opening your foundational documents up to 20 completely different external groups just asking for endless revisions, conflicting opinions, and basically a bureaucratic nightmare?
It is a completely valid question. And internally, it probably was a logistical headache to manage all that conflicting input. But if we connect this to the bigger picture, embracing that vulnerability was an absolute strategic masterstroke.
How so? Like, why put themselves through that?
Because of validation and patient outcomes. Think about you, the listener. As a patient, you don't just interact with nurses, right?
Right, obviously not.
You interact with doctors, respiratory therapists, pharmacists. If INACSL just kept revising the standards internally using only their own board, the standards would forever remain nursing guidelines.
Oh, I see.
But by securing feedback and implicit buy-in from 16 external healthcare organizations, they transformed the DNA of these documents.
They stress-tested them.
Exactly. They stress-tested their theories against different organizational cultures, different clinical priorities, and entirely different educational philosophies.
Wow.
That 2014 external review process is the exact moment these transitioned from being a really good internal idea to being universally validated best practices for the entire medical field. They traded short-term bureaucratic pain for long-term global authority.
Okay, when you frame it around the patient experience, that makes total sense.
Hmm.
They were proving that these standards worked for the entire healthcare ecosystem,
Absolutely.
which perfectly sets up the next evolution. Having secured that massive industry validation, the standards had to address the elephant in the room. Modern medicine is not performed by lone wolves.
No, it's highly collaborative.
Right. It is performed by complex teams.
Precisely. The nature of medical care was changing rapidly, and if the standards didn't stretch to cover that complexity, they would just become obsolete.
Yeah, what did they do?
So in 2015, they added entirely new areas of expertise to the framework, most notably something called Simulation-Enhanced Interprofessional Education,
Okay, wait.
often referred to as SIM-IPE.
Let's pause on that because SIM-IPE sounds like very heavy academic jargon. What does that actually mean for the people practicing it?
It's simpler than it sounds. It just means training the team as a team.
Oh, okay.
Historically, surgeons might train in one room, nurses in another, and pharmacists in another. But in the real world, communication breakdowns between those different disciplines are a leading cause of preventable medical errors.
That makes a terrifying amount of sense.
Yeah. SIM-IPE mandates that the simulation includes multiple professions working together. So you have a nursing student, a medical student, and a pharmacy student, all standing around the exact same simulated patient, learning how to communicate clearly during a crisis.
Wow.
It bridges the gap between the professions before a real patient's life is on the line.
That is incredible. They are literally simulating the communication, not just the clinical skills.
Right.
And that philosophy of expanding what a simulation covers brings us to the really massive shift in our timeline, the one that completely redefined the scope of what they were doing, which happened in 2021.
Yes, the 2021 update was a true watershed moment. They added 2 more critical areas of expertise to the standards: pre-briefing and professional development.
Here's where it gets really interesting to me. I was trying to wrap my head around why officially adding pre-briefing and professional development was such a monumental deal.
It's a big shift in perspective.
It is, and the best analogy I could come up with is comparing a medical simulation to a massive Broadway theatrical production.
Okay, I like where this is going.
So, for a long time, the focus of the standards was primarily on the performance itself, right? The time the actors are actually on the stage under the bright lights, the moment the mannequin starts flatlining.
The main event.
Right. That is the simulation itself. But adding pre-briefing to the standards is like realizing that the play's ultimate success is entirely dependent on the table reads and the safety briefings beforehand.
Absolutely.
The actors need to know the context of the scene, they need to know the safety rules of the stage, and they need to feel psychologically safe to make mistakes and learn from them without getting fired.
Yes, psychological safety is huge in simulation. If students are terrified of failing, they won't take the necessary cognitive risks to actually learn anything. Pre-briefing sets that stage.
Exactly. And then you have professional development. To stick with the theater analogy, that is like the ongoing acting classes for the directors and the producers.
Right, the educators themselves.
Yeah. It is the formal acknowledgement that the educators running the simulation need continuous training and skill building just as much as the students participating in it.
They can't just stagnate.
No. By adding these in 2021, they expanded the timeline of what actually counts as the simulation. The learning doesn't just happen when the heart monitor starts beeping. It happens in the preparation and the continuous education of the staff.
That is a brilliant analogy, and it perfectly captures the holistic shift in medical education. But alongside adding those expansive new sections in 2021, there was another massive, incredibly symbolic change.
The great rebrand.
Yes, they made the bold decision to drop the INACSL acronym from the official title of the standards.
Just completely removed it.
Yep. They re-released them to the world simply as the Healthcare Simulation Standards of Best Practice. And this raises an important question. Why give up that hard-earned brand recognition?
Yeah, you spent over a decade building the definitive gold standard in medical education. Why take your own name off the marquee?
Because, thanks to all that external validation and interprofessional focus, it wasn't just theirs anymore.
Exactly.
Dropping the prefix signals a deliberate, selfless shift toward absolute universality. It says to the global medical community, these aren't just for nurses. These aren't just for our specific members. If you are training paramedics in Australia, surgeons in Canada, or respiratory therapists in Japan, these are your standards now.
That's powerful.
It is the ultimate evolution from that small 2009 roundtable. They built a framework so robust and essential that it literally outgrew its own creators.
It is incredibly selfless, institutionally speaking. They gave their life's work to the broader healthcare community to ensure better patient care for everyone.
They really did.
And that brings us right up to the present day, because we don't just want to talk about history. We want to see these living documents in action today, right now in the spring of 2026.
The application of it all.
Right. How is all this foundational work actually manifesting in the real world right now?
To see that, we just have to look at the organization's current calendar of events. The archives highlight a few upcoming dates that perfectly illustrate how these standards are actively shaping the absolute cutting edge of medical education right now.
Right. Let's look at April 6th, 2026. There is a live webinar on the calendar titled Leveling Up Competency, a SimZones Approach to OSCE Design.
A very technical title.
Yeah. Now, for you listening, OSCE stands for Objective Structured Clinical Examination. And the best way to visualize an OSCE is to think of it like a highly intense medical escape room.
That is a very stressful but very accurate visual.
Right. So the medical student walks into a room. There's an actor pretending to have a specific complex ailment. A timer is ticking.
The pressure is on.
Exactly. And an examiner is standing quietly in the corner with a clipboard, grading every single question the student asks, every place they touch, and every decision they make. It is a highly specific way of testing clinical skills.
It's intense.
And the fact that they are hosting webinars on designing these escape rooms using specialized competency zones shows you how incredibly sophisticated the application of these standards has become.
It really does.
Yeah.
It proves that simulation has moved light years beyond just, let's pretend. It is about highly structured, measurable competency mapping.
Right.
But the next event on the 2026 calendar is perhaps even more telling about where the field is heading.
Yes, April 30th, 2026. Another live webinar, this one titled Integrating a Trauma-Informed Approach in Undergraduate Nursing Student Simulation Education, Strategies for Simulationists.
This is a big one.
It is. So what does this all mean for you, the patient? I want you to visualize a nursing student today in 2026. When they walk into a simulation center, they aren't just being taught the mechanics of how to push an IV or how fast to do chest compressions.
It's deeper than that now.
Way deeper. Guided by these living standards, they are learning to view the patient through a trauma-informed lens.
Which is profound. They are being taught to recognize the psychological state of the human being in the bed. They are learning how a patient's prior personal trauma might affect how they react to medical care, physical touch, or clinical environments.
Exactly. And they are practicing all of that nuance within a simulated environment, guided by a framework that started as a simple conversation about baseline competencies 17 years ago.
The growth is just amazing.
And all of this ongoing education, these webinars, this continuous pushing of the envelope culminates in their major upcoming gathering, which is the INACSL 26 annual conference taking place on June 10th, 2026.
The big event.
Yeah, thousands of professionals coming together to continue iterating on the very standards we've been discussing.
And that June conference is the ultimate proof that these standards are truly living documents. If the standards were static, they would have frozen in time, only ever covering the mechanics of medicine.
Like just the physical interventions.
Right. But the inclusion of modern, deeply nuanced concepts like trauma-informed approaches shows the standards constantly adapting to our contemporary societal and psychological understandings of patient care.
Yeah.
The simulation isn't just about treating the physical body anymore. It is about treating the whole human being.
It really is incredible to track that journey. So, to do a quick recap of what we've unpacked today, we started in the unstandardized void of 2009. We saw a board of directors recognize a massive, dangerous gap in how medical professionals were being trained.
The Wild West.
Exactly. We watched them painstakingly build a recipe box template in 2010, debut it in Vegas, and immediately subject their ideas to the harsh scrutiny of their peers.
Right.
We explored the crucible of 2014, where they bravely handed their hard work over to 16 external organizations to destroy the echo chamber, turning an internal guideline into a universal benchmark.
A genius move.
And we tracked the massive expansion through 2015 and 2021, addressing team communication, psychological safety, and ultimately dropping their own acronym to give the healthcare simulation standards of best practice to the entire medical world.
And we see it culminating right now in the spring of 2026 with highly sophisticated, trauma-informed interprofessional training happening in real time. It's preparing professionals for exactly what patients need today.
It really is.
But looking at that incredible timeline of adaptation leaves me with a final thought I'd like to pose to you, the listener, to ponder on your own.
Oh, lay it on us.
We have seen how drastically these standards had to evolve from 2009 to 2021 just to keep up with the changing landscape of physical simulations and interprofessional dynamics. But how will they need to evolve over the next decade?
That is the million-dollar question.
Right. As emerging technologies like AI-driven virtual patients, large language models acting as infinitely responsive clinical cases, and fully immersive haptic VR environments become the daily norm in medical schools, what happens then?
Yeah, when the mannequin is entirely digital.
Exactly. Will the fundamental definition of best practice have to change entirely when the simulation is no longer happening in a physical room with a plastic mannequin and real actors, but entirely within a digital space?
Yeah.
I mean, how do you standardize an algorithm?
That is a brilliant and slightly intimidating question to leave on, because the medium of the training is changing faster than ever, but the stakes, our health, our families, human lives remain exactly the same.
They never change.
Right. We hope this deep dive has given you a new appreciation for the hidden architecture of medical education. Keep questioning how the systems around you are built, and the next time you are sitting in a hospital or a clinic and you marvel at the calm, coordinated precision of the team treating you, remember the invisible scaffolding.
The decades of work.
Yes, the decades of debate, the external audits, the living documents that made that precision possible. Thanks for taking this deep dive with us.